Everybody. Welcome to today's Innovation and Precision Eye Health webinar series. This is brought to you by NUS Center for Innovation and Precision Eye Health, as well as the Department of Ophthalmology. So today, we are privileged to have a very distinguished speaker who will be telling us about myopia and glaucoma. Let me introduce you to Professor Anthony Khawaja, who is based at UCL Institute of Ophthalmology and Moorfields Eye Hospital in London in UK. He is currently a UK Research and Innovation Future Leaders Fellow and a Lister Institute of Preventive Medicine Fellow. He has completed a Wellcome Trust-funded epidemiology master's and PhD program at the University of Cambridge, as well as a Berkeley Fellowship at Harvard Medical School. His research focus centers around genetics and the environmental causes of glaucoma. This is a very interesting topic, and he will attempt to teach and mention about the association between myopia and glaucoma. Let me tell you a bit more about his background. Anthony's aim is to develop prediction models that enable efficient population screening of glaucoma and a personalized glaucoma care in the clinics. He is currently the chair of the SNOMED International Eye Care Clinical Reference Group, co-chair of the NHS England Imaging Interoperability Task and Finish Group, and the past president of the European Eye Epidemiology Consortium, as well as director of the European Society of Ophthalmology Leadership Development Program. In this talk, Professor Anthony Khawaja will summarize current evidence on the association between myopia and glaucoma, including epidemiological studies and clinical findings. Anthony, over to you.
Thank you very much. Let me see if I can share my slides and remember to share sound, which I am doing. So we'll go here. Victor, if you could let me know.
Yep, I can see your slides now.
Okay, perfect. And what I'll do is move this one over to this screen, which will be better. Okay, great. Well, thank you for the introduction. I have a lot of friends in Singapore, and actually being invited to this webinar was, a kind of a typical thing. Our friends and collaborators in Singapore are such warm hosts that, I met some of the organizers of this webinar at a Singapore event at ARVO, and we discussed this topic and over dinner, and it was like, well, it would be lovely if you could speak about it. So I will be speaking about this topic, which I think is very interesting, actually, for people who are interested in glaucoma, but also people who are interested in myopia. And then at the end, if we have time, sort of build on some of the other controversial or more complicated risk factors for glaucoma and how we can use modern epidemiological tools to help us determine whether whether one thing really causes another thing. So Victor, you can see my slides okay?
Yep, good, all good.
Brilliant. Okay, so these are my financial disclosures. I guess some are relevant in that some of these companies make treatments for glaucoma, and some are entering the myopia space too. So I don't know about the other clinicians on this call. You're maybe more used to myopia, seeing people with high myopia than we are, though I feel as though I see a lot of patients with high myopia. But knowing whether these eyes have glaucoma or not, it can be extremely challenging. Yet, despite this, myopia is really, it's from medical school, I've always said, oh, well, it's one of the major causes, it's a major risk factor for primary open-angle glaucoma. Whether you look in the textbooks that you use, these are some of the ones we use in the UK, or you go to the guidelines, and I know you have your APAO guidelines. These are the European Glaucoma Society ones. Myopia is factually written as a risk factor for primary open-angle glaucoma. And why is that? Why, when we read about different conditions in Kansky's book and it says these are the risk factors, where does that information come from? Is it just experts? Or, well, no, it comes from epidemiological studies. That's how we know. And when you look at cross-sectional population-based studies for eye disease, and there's more than this now, but back here, this was a systematic review done at that time when, at the time when people were saying myopia is a risk factor for POAG. And then you can look at, do people with myopia have more glaucoma? And in all of these studies, you can see that the main effect estimates are all to the right of this line. So the odds ratio is greater than 1. And so there is more glaucoma in people who are myopic than people who aren't myopic, at about nearly 2 times fold. So people with myopia have about twice as much glaucoma as people without myopia. So does that mean it's a risk factor? Well, these are cross-sectional studies. We all know about the pyramid of evidence. We're taught about this in our undergraduate education. We know at the top of the pyramid systematic reviews of randomized controlled trials. So that's certainly not that level of evidence. All of that is actually just cross-sectional studies. That's like barely halfway up the pyramid. So it's not great evidence that myopia causes primary open-angle glaucoma. But we've got better evidence than that, haven't we? We can go up the pyramid a little bit. We can go to cohort studies, because some of these population-based studies didn't only look cross-sectionally, they also looked longitudinally. So if at baseline you exclude everybody who's got glaucoma and then just follow those people without glaucoma over time, then you can see, well, do the myopic people without glaucoma at baseline, are they more likely to get glaucoma in the future than those who aren't myopic? And not all population-based studies have done this, but some have. The Barbados Eye study didn't report. Rotterdam study found only association with high myopia. The Visual Impairment Project looked at it and myopia was not associated. Blue Mountains, for ages, I thought it was a negative finding, but in their most recent study, they find a signal for just high myopia. And in the Los Angeles Latino Eye study, it was a borderline association with that axial length. So when you start to look longitudinally, the waters get a bit murkier. And there's a big problem with these types of studies in that you're trying to ascertain glaucoma just with one-off lot of tests. We're just looking at a one-off set of visual fields and maybe optic disc images, glaucoma, yes or no, and then excluding line and then saying it's present at follow-up. Maybe the ones that were present at follow-up were actually present at baseline, but your tests weren't quite good enough to pick it up, and so on. So truly knowing that it's incident POAG and it wasn't actually there at baseline or before baseline is very difficult. We know in glaucoma, we need repeated tests, but we have better evidence than this, don't we? We've got studies that have measured for glaucoma, done the tests such as visual fields at multiple points in time. We've got really good trials in glaucoma. So what about the early manifest glaucoma trial? So that took people with glaucoma, randomized to treatment or not treatment, and then followed up over time, looking at progression of glaucoma. Myopia was looked at, and it wasn't associated with the progression of glaucoma. What about the ocular hypertension treatment study? That's taking people who don't have glaucoma, but just high pressure, and looking at who converts to glaucoma. If myopia really caused glaucoma, wouldn't you expect the myopic people in the ocular hypertension treatment study to convert more to glaucoma than those who are not myopic? No, not at all. It wasn't associated. What about the UK glaucoma treatment study? That took people with open-angle glaucoma and compared latanoprost versus placebo. In neither of the group arms of the study or overall was myopia associated. In fact, and I was involved in this analysis, at some point, myopia was protective. Myopic people were less likely to progress than people who were not myopic. So how do we put this together? Then when you look cross-sectionally, there's this really strong association. When you look longitudinally, it becomes weaker, either not there or maybe only driven by high myopia. When you look for progression or conversion, you're seeing nothing, or even maybe myopia being protective. So how do we make sense of this? Does myopia cause POAG or not? Is it only driven by high myopia? Is it that moderate and mild myopia doesn't increase the risk of POAG, it's just high myopia? Well, I don't know, I find that difficult to swallow because actually high myopia is relatively uncommon in population-based surveys. Yes, they were excluded from those trials because they're harder to measure. Could it be misdiagnosis? Could it actually be that you're more likely to misdiagnose myopia, misdiagnose glaucoma in people who are myopic because they maybe have a visual field defect from myopic degeneration instead, or from an abnormal tilted nerve, or the nerve might look suspicious just because of the myopic anatomy rather than true myopia. Maybe that might explain why people myopia is protective against progression, because it's a marker of people who don't actually have glaucoma, potentially. Could that be it? I mean, going back to these pictures, if we diagnose glaucoma in these eyes and they don't actually have glaucoma, of course, they're less likely to progress rather than be more likely to progress. So part of the problem is glaucoma status ascertainment is less clear in myopic people. It might be less accurate. So can we do something more objective? Well, one objective thing is an IOP measurement, right? That's unbiased, especially if you're measuring with an automated instrument rather than the awful Goldman tonometry, which can be so subjective according to the operator. But a lot of the ways we measure IOP is actually very objective. And so we looked at this some time ago in the European Epidemiology Consortium. We looked at multiple factors that associate with intraocular pressure. We were trying to say, well, what might influence intraocular pressure? And we looked at myopia. And here you can see that everything is to the left of this line. And that means that in pretty consistently across these studies, more myopic eyes had a higher IOP. Okay. People in the past wondered, is it just high myopia that's driving the association? In this study, we could look across the range, and actually it doesn't seem to be just high myopia has a higher IOP. Actually, as you go into hypermetropia, hypermetropes had a lower IOP. So it didn't seem to be something just driven by this high end. It seemed to be linear across the whole end. But then I was actually a PhD student at this time, and I looked through all of the literature saying, well, why would a more myopic eye have a higher IOP? And then I asked all of the smartest people I knew. I couldn't find anything in the literature. I asked all of the smartest epidemiologists. They didn't know. But I had to write something in the paper. So this is what I wrote. What remains unclear is why IOP is higher in myopic eyes. A possible hypothesis is that abnormal elongation of the eye is associated with the degree of malformation of drainage angle microstructure. Trying to sound intelligent without any basis for it, it was, not good enough, really. And I don't know what prompted this, but it was like a couple of years after the fact, I realized, well, look, all of those studies were cross-sectional. And just because we had IOP as the outcome measure, we were assuming that because myopia is associated with higher IOP, it's the myopia that's causing higher IOP. But this is a cross-sectional study. Why weren't we asking the question, is it higher IOP that contributes to myopia? Now, when you look at that in the literature, suddenly things pop up. And there are quite a few studies that suggest if you lower IOP, particularly in eyes with high myopia, you reduce myopia. Now, some of the epidemiologists there's now 320 of you, so I assume there's at least 20 epidemiologists. You remember when you're trying to work out whether something's causal, there's the Bradford Hill criteria of causation. And one of those strongest pieces of evidence that one thing causes another, other than doing a randomized controlled trial, is if you can intervene to lower the exposure or modify the exposure, and then you see a change in the outcome, that's very strong evidence that A causes B. So here, if you can intervene to change IOP, here lower IOP with trabeculectomy, and you reduce myopia, which you do, by the way, then that's good evidence that IOP contributes. So maybe myopia doesn't cause high IOP, but high IOP causes myopia. But that's all still sounds pretty theoretical, right? We know that the top level of evidence is randomized controlled trials. That's what we base most of our medicine on. Most of glaucoma treatment is based on randomized trials that show if we lower IOP, we reduce the risk of myopia progression. And we randomize people to lowering IOP or not lowering IOP. So can we do the same for working out whether myopia causes glaucoma or not? Why is randomization important? Well, it reduces confounding factors. That's critical. Any observational study, don't believe people when they say, oh, we did propensity score matching, we adjusted for this, that, and whatever. You cannot, from observational evidence, get rid of confounding. The only way is to do randomization. The other thing is reverse causality. What's cause and effect? What came first? The only way you can do that is if you examine people before you introduce the exposure and then look afterwards. So cause and effect becomes clear when you do a randomized controlled trial. So easy. All we need to do is randomize people to be myopic or not be myopic. And once we've randomized them into the no myopia and myopia group, we just follow them up over time and see who develops primary open-angle glaucoma. And if the people we randomize to be myopic get more POAG, then we'll know, well, myopia causes POAG. Great, right? Well, hang on. How do we randomize people to be myopic or not be myopic? We can't do that, can we? Well, it turns out we can. It turns out we're all part of a naturally occurring randomized controlled trial. And that's because of the way we inherit genetic variation from our mum and dad and through the generations. It is random. And so that's the basis of a technique you'll have all heard of called Mendelian randomization. And this was popularized by a mentor of mine and one of my epidemiology heroes, George Davies Smith. And so he's done a little short video that explains Mendelian randomization, I think, very nicely and eloquently. So hopefully the sound works. Victor, if it doesn't, let me know and we'll try and fix it. But this is a nice video by him introducing Mendelian randomization.
Epidemiologists are interested in understanding factors related to health and disease. Do smokers tend to die younger than non-smokers? It certainly looks that way. But disentangling cause and effect can be difficult. Smokers are different on average from non-smokers. They're more likely to drink heavily and have less healthy diets. But even if we measure these confounding factors, we may not measure them perfectly, or there may be others that we haven't measured. Also, as people become ill, they may cut down or give up smoking, which could wrongly suggest that reduced smoking leads to worse health. We could randomly assign 50,000 people to smoke and 50,000 people to not smoke and follow them up to monitor their health. This removes the possibility that any other factor could be responsible for any differences we see in their long-term health. But this is neither ethical nor practical. Fortunately, we have all been recruited into an experiment without knowing it at the point at which we were conceived. Our genes, which are passed on randomly from generation to generation, influence how much we eat, sleep, drink, smoke and more. These genetic influences are not affected by anything else you may or may not choose to do in your life. They're not related to confounding factors. We can use this knowledge to learn about cause and effect, grouping people according to their genetic code. This method is called Mendelian randomization. For example, smokers who carry one version of a gene called CHRNA5 tend to smoke less heavily than those who carry a different version. When we group people according to which version of this gene they have, we find that the people with the version of the gene associated with heavier smoking do indeed die younger. But is the gene influencing how long we live in some other way? We don't think so. When we look at the same gene in non-smokers, there's no effect on life expectancy. so the effect must be driven by smoking. Using this method, we can show that smoking causes lung cancer, heart and respiratory disease, and many other diseases, but does not seem to influence depression or anxiety.
Okay, thank you, George. So, can we use Mendelian randomisation to work out, does myopia truly cause glaucoma? So the first step, you need to identify the genetic instrument. So which of the gene variants that we inherit from our parents, meaning we're more likely to get myopia or less likely? Well, that's actually easy because we've had for a long time big genome-wide association studies, and that's included collaborations with Singapore. And let's take the strongest genetic association for myopia in the GJD2 gene. And this top variant, whether you have the allele A or T, is very strongly associated, or very significantly associated with whether you get myopia or not. So if you take, we could take the 331 people, 333 people on this webinar, and if we had your genetic code and we could look at this genetic variant, you would either be AA, AT, or TT. And amazingly, when we separate you out in those groups, you will have different amounts of myopia. The people with AA will have more myopia than the people who are TT, and those who are AT will be in between. That is for sure, because this is such a strong variant for myopia. So then, once I've separated you out into those groups, you are otherwise the same because you've been randomly allocated these. So if I looked at your height, you would have the same height in these groups. If I looked at your weight, you would have the same weight. If I looked at all of these other things, you will be the same in these groups. The only difference, broadly speaking, is that this group will have more myopia than this group. So it's a randomized controlled trial. These people are just randomly are assigned to be more myopic. Now, if we measure IOP in each of these groups, if it's exactly the same across these groups, if there's no significant difference, then that suggests myopia doesn't cause a difference in IOP. But if we find a difference, and it might not even, doesn't need to be a big difference, but a significant difference, then this suggests myopia does cause a change in IOP. Now, what do we do? Do we just look at one genetic variant? Even though we've identified here, this is from 2020, over 400 genetic variants that cause IOP, that cause myopia. So can we do that same test 400 times? Well, no, we don't. What we do is a dose response. So here you plot each of those genetic variants, the top ones at each of those points, and plot its association with myopia against its association with whatever you're looking at, IOP, primary open-angle glaucoma. And if genetic variants that increase myopia a bit also increase glaucoma a bit, or increase myopia a lot, also increase glaucoma a lot, then you'll get the variants coming across the diagonal line. There will be a dose-response relationship. And there are various different sensitivity analyses which are beyond the scope of this talk, but trying to look at the different assumptions you make when you are doing this type of study. But essentially, you want these lines, if A does cause B, these lines would be diagonal. So if you see these lines looking very diagonal, and you can look at the statistics for the slope of it, this gives you strong evidence that A causes B. Myopia causes higher IOP. If the lines are looking quite horizontal, then it seems as though, genetic variants that cause a higher risk of myopia are not associated with higher IOP consistently with the same dose response. Therefore, it doesn't seem as though myopia causes IOP. So if the lines are horizontal, that seems to show less evidence for causation. Okay, so we did this for myopia and IOP specifically. And we did it, does myopia cause IOP? And these are the results. You can see the lines aren't very diagonal here. They're actually almost horizontal. And when you look at the statistics for those lines, the p-values were nowhere near significant. And so our conclusion here was that myopia does not cause a change in IOP. What if we do it the other way around, though? We were thinking, well, could the associations be for the other way around? Is it that higher IOP causes myopia? And look, these lines are now a lot more diagonal, and all of the sensitivity analyses still showed a p-value of less than 0.05. And so this, to me and us, thought this is quite strong evidence that higher IOP causes myopia. So at this point in time, this was a very striking finding. And this, in my mind, challenges the concept that the cross-sectional association we see between myopia and POAG is because myopia causes POAG. Actually, I think it might, a lot of it, or at least in part, is driven by it's the other way around. It's eyes that have a tendency towards higher intraocular pressure cause myopia. And by the way, we've showing evidence now that people with a high genetic tendency for higher myopia in adults, that genetic tendency, you can look at it in children. And even though it's hard to measure IOP in children, we are seeing that that genetic tendency for higher IOP is associated with a higher IOP, even in children. And maybe this isn't surprising. Maybe we've known this for a long time. And if we think of two examples, one is before the sclera is, for the majority of us, our sclera becomes rigid and doesn't change much, doesn't change too much after a certain age. And that's why it's only in congenital glaucoma that the eye grows substantially. But we know that when the IOP is very high in a baby, the eye can grow very myopic. It grows huge. And so clearly, when the IOP is high and there are other factors present, you can definitely cause myopia. And as I alluded to earlier, even in adults where the eyes stop growing, if you go and do a trabeculectomy, you will get less myopia. And in eyes that we know have a tendency to grow more, highly myopic eyes, you can actually reduce myopia by quite a lot if you reduce the intraocular pressure by a lot. Now, it's a bit like when you're taught medicine at medical school, you don't, or at high school, things are made a little bit more simpler. Things are a bit more sort of dogmatic and easier to understand. And I've sort of purposely done that. Obviously, nothing is as simple as this. And, for me, I still believe quite strongly that at minimum, part of the association that we see is not that myopia causes POAG, but that the higher IOP you get with the tendency towards a higher IOP you get in people who eventually get POAG has contributed to myopia in those individuals. I have no doubt that that is a substantial part of the association. But, I think that there's good evidence that it could be bidirectional. Mendelian randomization is complicated. It depends on which summary statistics you're using from which genome-wide association study. And that's always a moving target. There's always new studies coming. I've personally looked at it again since then using some different data sets that I didn't have originally. And there does seem to be something in the other direction. So while we didn't find myopia causes high IOP, depending on which genetic results you use, you can find evidence that myopia causes higher IOP using Mendelian randomization. This is a lovely paper from Rachel Chong and Qingyu Chen, and they thought it was bidirectional, but POAG causes myopia and myopia causes POAG. Maybe they're on this webinar and they can clarify later on in the discussion. But what's interesting is, I think if you talk to clinicians and they think myopia causes POAG, they don't say, well, myopia causes POAG through higher IOP. Clinically, people believe, well, myopic eyes, the optic nerve head biomechanics is all altered. They just have a susceptible optic nerve head. So if that's the case, they should be finding that refractive error causes POAG through more disc factors than IOP, but they didn't find that. It was through IOP. Now, one residual problem that is very difficult to address, although we're trying to do that, is the problem that we measure IOP much worse than we measure refractive error. If I measured Victor's refractive error now and tomorrow and in 3 weeks' time and in a month's time, it would be very similar. The noise isn't too bad. Now, if I measured Victor's IOP today and tomorrow and this evening and whatever, it could be all over the place. There's so much noise. So a genetic variant that is causing myopia through IOP by causing higher IOP might still look more associated with refractive error than IOP simply because of that noise. And accounting for that is very difficult. So Mendelian randomization can take us so far. I think it's really opened up a compelling hypothesis that IOP causes myopia, but the results aren't necessarily always as clean as I've shown you. But hopefully the way is what I've shown you is a nice story, and it demonstrates this really powerful technique we have now that helps us tell us what causes what. Now I want to shift gears a bit to another thing another technique that I think can really help us understand data, and that's simulations. And I'll start off with an example outside of medicine. There was a TV show called The Monty Hall Show, and there's a Monty Hall problem. And what he did is the contestant at the end of the show was given the chance to win an expensive car, a sports car, and he had 3 doors, and behind one of the doors was this car, and behind 2 of the other doors was like nothing, like a booby prize, nothing. And so he would ask you, pick one door. So let's say I picked door 1. He would then open one of the other doors and say, look, the car's not behind here. Now you know that. Do you want to switch? So if he opened door 2, I picked door 1, and he said, look, it's not behind door 2. Do you want to switch to door 3? Should you switch? That's the question. And for some people, they'd say, well, it's 50-50 now. Doesn't matter. I don't think I'll bother switching. But actually, the answer is you must always switch. And that's what this clever lady said in this magazine. And she said, you must always switch because the probability doubles. You will be twice as likely to get the car if you switch. You'll go from being more likely to not win than win to being more likely to win than not win if you switch. But this confused people, and very smart, it caused an outcry, and people were writing in going, very smart people who were PhDs around the US wrote back in saying, this, you need to sack this person. It's ridiculous. It's just 50-50. And they had to fight back. And one of the most convincing ways they fought back that you should always switch was to do simulations. And if you want, when you get home tonight, you can do this. You can play it with your partner. And if your partner always doesn't switch, they will get it right 1/3 of the time. They will win 1/3 of the time. If they always switch, they will get it right 2/3 of the time. They double their chances. And it's not intuitive. Intuitively, you'd think it doesn't matter. But the simulations proved it. So why is that relevant? Something that really annoyed me in medicine was we'd love to know, does the perfusion to the optic nerve influence glaucoma risk? And so ocular perfusion pressure is a simple way, apparently, of measuring it. You take blood pressure and you minus, which is the pressure going to the eye, and you minus intraocular pressure because that influences the veins and the pressure leaving the eye. And that gives you a brand new number, apparently, called ocular perfusion pressure. And some of our best studies in the world all we're all guilty of this, including my good friends in Singapore, saying, well, look, it's associated with glaucoma, therefore perfusion to the eye is important for glaucoma. But there's problems with this. And that's one of the main problems, is that intraocular pressure is part of ocular perfusion pressure. So you could just have higher pressure in the eye, and that gives you a lower perfusion pressure because this is minus. And maybe the association between ocular perfusion pressure and glaucoma is just reflecting higher intraocular pressure. But people said, oh, but we adjust for intraocular pressure. So let me now, some very basic education. When you do a regression model and you look at, does IOP associate with glaucoma, the predictor and the outcome, how do you interpret the results you get for IOP? Well, the result is the increase in glaucoma per one increase in IOP, per 1 millimeter increase in IOP. What if you put more terms into a multiple regression? If you put in age, then you change the interpretation of the IOP term. It becomes the increase in glaucoma per millimeter increase in IOP whilst holding age constant. Now that's a really important caveat here, but that's amazing because that's how we can account for age. You can account for confounding by age. So this is a really powerful way that we can use multiple regression. But let's go to the ocular perfusion pressure example, which is blood pressure minus IOP. So it's the increase in glaucoma risk per 1 millimeter increase in this. And as we've said, that might be less just from higher IOP. But what if we adjust for IOP? What does the result for this mean? Well, it's the increase in glaucoma risk for this increasing in one unit, but whilst holding IOP constant. Now, if you hold IOP constant, then how can this increase? It can only increase by an increase in blood pressure. So now the results for this, when you adjust for IOP, just reflect blood pressure, nothing to do with this magic new number. So if you look at BP minus IOP alone, it might be IOP driving it. But if you look at BP minus IOP adjusted for IOP, you're just looking at blood pressure. This apparent new number doesn't tell you anything new. Now, I tried to explain this to the field a long time ago when I was a PhD student, and I thought I made it very clear with this paper and these equations, but no one listened and people kept on publishing on ocular perfusion pressure. So I thought I need to think of some new way. One way I did is I got the most stupid variables I could from my population-based study, EPIC Norfolk, and I showed that shoe width is not associated. I think it was left shoe width wasn't associated with glaucoma at all. But if you did shoe width minus IOP or did anything with IOP, it became very significantly associated with glaucoma. Left ear length was warning about chance finding. It was getting close to being associated with POG, but it becomes very associated if you take away or add IOP. What about self-reported sex drive age 30? Not associated with glaucoma, but if you take away IOP, add IOP, and so on, it becomes significantly associated. So I thought I'd cracked it here, but when I first gave this talk, someone came up to me at the end of the talk and they said, I like good talk, thank you. English wasn't their first language, but they said, is it really true about the shoe width? And I said, oh no, okay. So they missed the point. Plus, people would still say, well, what if you adjust for IOP? And that was the sticking point that people didn't understand. They didn't understand my slides that I showed earlier. They didn't understand the regression model. And this is when I partnered with Nomdo Jansonius from Groningen in the Netherlands. And we did this simulate. We made data and we showed that if you've got ocular perfusion pressure and you adjust for IOP, you get exactly the same results to however many decimal points you want to look at. If you just look at blood pressure, diastolic blood pressure and diastolic ocular perfusion pressure, same for systolic, same for mean arterial, whichever way you looked at it, you get exactly the same. So then I could tell people, and they believed this when I said this, I said, when you see a result of ocular perfusion pressure adjusted for IOP, remember, you're just looking at blood pressure. And I'll come back to that. Another way that we could look at leverage simulations was for central corneal thickness, because this confused people. I don't think there's any evidence that says central corneal thickness is a biological risk factor for glaucoma. You can look at this paper, which helps explain why. And when we made a data set, we simulated a data set that said, because we know in that when we simulated, we made CCT not cause glaucoma, but we made CCT influence measured intraocular pressure from true intraocular pressure. And we know true intraocular pressure because we made the data, we simulated it. And when you look crudely, central corneal thickness isn't associated with POG, which isn't a surprise. These are 20 different simulations. Not a surprise because we made it to not be, even though a couple of times it was almost by chance associated. But when you adjust for measured intraocular pressure, you make it associated. Or when you select for higher measured intraocular pressure, like they did in the ocular hypertension treatment study, you quite strongly cause an association between a thinner central corneal thickness and glaucoma. So it's an artifact related to that. And the simulations, I think, helped prove that. Genetics can as well, Mendelian randomization can as well. So lastly, just that, why stop there? Okay, ocular perfusion pressure, lower ocular perfusion pressure, we can't say that from the studies, but it does seem as though the lower blood pressure is being associated with glaucoma. So is that causal? Does lower blood pressure cause primary open-angle glaucoma? Well, how can we know for sure? It's an association, right? We've just shown how myopia and POG, it's not as straightforward as that. Can you do a Mendelian randomization? Well, you can. And actually, it's higher blood pressure is associated with higher intraocular pressure, not which you might associate with a higher risk of glaucoma. But when you look at the thickness of the ganglion cell complex, actually a higher blood pressure was associated, it's not a lower blood pressure that's associated with thinner ganglion cell complex you get with glaucoma. It's a higher blood pressure. And actually, I think this is more a metabolic syndrome. People with higher blood pressure are also more likely to have diabetes. And that's now we know is one of the earliest signs of diabetes is a thinner inner retina at the macula. So the opposite direction to what you'd expect if lower blood pressure caused glaucoma. And when you look at primary open-angle glaucoma overall, just a dead null. So Mendelian randomization doesn't seem to support blood pressure, lower blood pressure being a true causal risk factor for glaucoma. And so when people sometimes suggest, oh, people with low blood pressure should take more salt to raise their blood pressure to reduce the risk of glaucoma, I think they're on shaky ground, and we certainly have no good evidence for that. Why else? Why? What could the confounding factor be? Well, one thing is people with lower blood pressure, sometimes it might be because they're being treated for lower blood to lower their blood pressure compared to untreated people. Could it be the treatment for blood pressure? And we're finding more and more now, whether you look hypothesis free or directed, that a specific type of antihypertensive, calcium channel blockers, are associated with a higher chance of developing glaucoma. And so this is far from proof, but it could be one explanation. The last thing I'd say in the last 30 seconds or so, and I mentioned it earlier, that Mendelian randomization relies on genetic association study results. And these get more and more powerful as we do more and more work. This is our latest Manhattan plot. This work's under review now. There's now nearly 700 points on the genetic code, which are associated with primary open-angle glaucoma. So as time goes on, we can even go back to these questions and get clearer and clearer answers as we reduce the noise in our analyses. And so it's exciting times for causal epidemiology. And of course, I do none of this work myself anymore. I don't have time, but my lovely team who are really quite brilliant. The people who did the it's Skander, who was actually, when he was a medical student, did those analyses looking at Mendelian randomization of blood pressure for glaucoma-related traits. And that final Manhattan plot is all of these people working together. So I'm very grateful to them. I'm grateful to my funders, and I'm grateful to all my wonderful friends and collaborators in actually all of our collaborating institutes in Singapore. We have such a great and fruitful relationship. So it's an honor to be able to spend this hour with you. Thank you.
That's great, Anthony. I've heard you speak multiple times, and each time I hear you speak, I learn something new. You are just as entertaining as before, and that was a good one. Um, you have covered quite a broad aspects of Mendelian randomization, as well as how we can apply that to look at associations with glaucoma. And what I like about what you have covered in the past 40 minutes or so is that you are also debunking some of this myth, and how can we critically analyze some of these papers and the methods that are used to challenge what is in the literature. And that is important, because when we see our patients and as we counsel them, they ask us a lot of questions that's related to lifestyle, for example, or related to associations, because they want to know, apart from eye drops, apart from surgeries, are there anything that they can do to help them reduce the risk of glaucoma? So what you have covered really opens up possibilities, isn't it? And I am sure amongst the 300 plus participants today, you would have sparked inspiration and questions, and this will allow collaboration to happen. Allow me to at this stage introduce Associate Professor Clement Tan, who is the Cluster Director for National University Health System. He is a neuro-ophthalmologist by training, but has taken up a very keen interest in myopia, as well as the relationship with glaucoma. We also know, Anthony, that in this part of the world, we do see quite a fair number of normal tension glaucoma as well. And to add to the mix would be the high myopia amongst our meets. And to make it even more challenging is the increasing number of patients that have refractive surgery, laser refractive surgery. And that, when you add everything into the mix, it complicates matters, especially for diagnosis and for monitoring these patients. So let's kickstart the Q&A. Ladies and gentlemen, if you would like to raise a question, just type that in the Q&A segment, and I will curate those questions, and we will have them sent to Professor Anthony Khawaja for his response. So let's maybe invite Clement first to kickstart with the first question. Clement?
First, thank you very much, Victor. And Anthony, thank you for that very, Victor is right, entertaining shoe size and ear length. I'm not going to forget that one. But it does speak to the fact that research will find what you want it to find sometimes. And Victor is right. My journey into this is rather accidental, simply because then I get asked why this patient with high myopia, or why this patient with supposed normal tension glaucoma is getting worse despite all efforts to control the IOP, and that search has led to stumbling across a lot of people with high myopia who then seem to have this progressive visual field loss despite best efforts to control the IOP, and a desperate search for other causes often turns up nothing else. Actually, I think Daniel had a very interesting question there, which I don't know if you want to take first, because the question is whether you can test this out in animal model. But I just wanted to extend Daniel's question to ask the other step backwards. The challenge, at least as I'm seeing it, is having a better working definition of what is glaucoma, and specifically what is normal tension glaucoma, because a lot of the high myopia related glaucoma or high myopia related optic neuropathies we are finding, they do not have high IOPs. So they all sit in the range of low IOPs. The Japanese are treating every single one of them as a glaucoma and desperately lowering their intraocular pressure. So I think we live in first of all, a challenge of definition. And I wonder if you might first address the question of definition, since we've talked about Mendelian randomization and trying to define the problem. If the definition of normal tension glaucoma, perhaps. And then maybe Daniel's question about whether we can test such a model in animals.
Okay, I mean, a lot of big questions there. I think this thing about in some parts of the world, normal tension glaucoma being more common. One thing we do know, one of the most heritable, one of the most genetic things about all of us as humans is central corneal thickness, actually. It's one of the most heritable things. So we can, if we're going to predict, Clement, your central corneal thicknesses, if I got your parents' central corneal thicknesses, I could do it better than I could even your height, I think. It's like it's that heritable. And so it's a very genetic trait. And I think that corneas probably vary between ancestries, and there is some evidence for that. And I think people and I think you see it particularly in Japan and maybe South Korea, that the higher levels of normal tension glaucoma, I think they do have softer corneas potentially. And so it could just be that you're underestimating the true pressure. What's very interesting is also in these countries, I ask how often do you see ocular hypertension, which is a high pressure where they follow longitudinally, you don't get glaucoma. And it's like, well, we never see that. Whereas, maybe we do sometimes see that in other ancestral groups, particularly because they can get really thick corneas and they don't actually have high pressure. In terms of a definition, look, there's been many efforts to try and define it. For me, clinically, it's about longitudinal data at the early stage, and now I think with the correct OCT machine, I think you can look longitudinally, and I think we can start to get more confident. Of course, it's impossible in people with high myopia when you even longitudinally, changes could be related to what you'd call myopia. It then, in some ways, becomes semantics. And I would argue, on the basis of this talk, with some of the stuff that I told you there, and even on Rachel and Ching Yu's paper, they alluded to it too, that if you've got somebody with high myopia and the vision's getting worse, and you're like, God, is it the glaucoma? Is it the myopia? Because if it's the glaucoma and I need to do surgery, surgery is risky on highly myopic eyes. So maybe I don't want to do that. But one thing that might encourage you to do is actually, if someone's got progressive myopia, it could be, and there's no proof for it, but it could be that lowering IOP helps them too. And that might help you cross the line. I think with better tube shunts now, we use the Paul glaucoma implant, as I'm sure many of you do now, and that's tending to be quite predictable. I think we're getting the tools to safely lower IOP, even in highly myopic eyes. I think the threshold for doing it is lowering, even when there might be that diagnostic quandary. In terms of animal models, it's Daniel, the other way round. There is now IOP lowering, I think, has been shown to reduce the actual elongation in animal models. So it does work. Lowering IOP seems to reduce myopia progression in animal models. The other way around, I'm not sure. I don't think people have made mice myopic and then looked at whether they could get more glaucoma or not. I'm not sure about that. Paul, thank you for the question. Why is Goldman tonometry awful? I mean, I don't have time. We've only got 5 minutes left to say why. I mean, one thing is how operator dependent it is, and another thing is the prisms. If you, like us, have to use the disposable ones now, those Myers don't look clear anymore. I mean, it's just. But one of the big things is the corneal artifact, and now that there are tonometers that can help reduce the corneal artifact, I think we're compelled to use them really. And so at Moorfields, all of our patients at the glaucoma service have the ocular response analyzer. No tonometry is perfect. People with really narrow palpable apertures, I think the eye care is king. Same for children. I think the eye care is king. And look, sure, it might not be perfect, but it is probably the better. And if you're unsure, try multiple devices. And you have to accept it sometimes. You just might not know what the true intraocular pressure is. Is there any link of glaucoma risk with race and or ethnicity? Thanks. So interesting. So race, I think we're all part of the human race. And so that it's interesting terminology, whereas the US it's funny, race I think is like European versus non-European, but then ethnicity is Hispanic, but it's all wrong. So if you do genetics research, we're all a human race. We're different ancestry depending on our genetics, and then we're different ethnicity. There's the broader cultural thing. But both, because they're so strongly correlated, we see the same effects with ancestry and ethnicity. And essentially, yes, people of, say, African ancestry are more likely to have primary open-angle glaucoma than those of European ancestry, and Asian ancestry somewhere in between. But for angle closure glaucoma, Asian ancestry have the highest risk. So it depends on the type of glaucoma. And thanks, Paul, for the supporting paper there.
Anthony, we just have a bit more time left. Perhaps you could excite the participants by sharing from your perspective with all the data you have. And I'm from your talk, I figured you are someone that would like to look at novel associations with glaucoma. Were there anything interesting that you would highlight that say, that's more work that needs to be done, something more interesting that comes out with association with glaucoma?
Yeah, I mean, I think the biggest things the real big thing that I think should lead to a new treatment but hasn't yet is this strong genetic signal for the development of lymphatic vessels. And so it's helped us understand that actually the aqueous outflow system is a vessel, that Schlemm's canal and collector channels are a vessel, and lots of biological factors. Now with our larger GWAS, we shared some of this at ARVO, we're getting so many more signals that are all pointing to this. And it's actually stuff that's beyond trabecular meshwork. There's problems at trabecular meshwork and the crosstalk between trabecular meshwork and that side of Schlemm's canal, but there's also stuff that's beyond that. So previously we thought everything's here, and that part is really important. It gets stiffer as you get older, and as you've got more variants that affect things like TGF-beta signaling and other pathways, and then you do get resistance there, but there's also resistance beyond that. Rho kinase inhibitors, we know already sort of target part of that. It might target other parts. But given now the biology is converging and we're really seeing some very strong pathways, I think that's going to do two things. I think one, we might get new pharmacological treatments. And by the way, don't listen to people when they say IOP is done. We now need neuroprotection. Well, we love neuroprotection, but IOP is not done. Otherwise, if it was, then you wouldn't ever need to do a trabeculectomy or a tube shunt. And unfortunately, we still have to do those surgeries, which are still not good enough. They're not as predictable as something like phaco. So we need safer treatments for our patients, especially the highly myopic ones. And I think we should get those. But also just using the genetic code to predict. And I think we'll be using the genetic code to work out who has a glaucoma problem that's predominantly at this part of the aqueous outflow or that part, and then we can potentially do more targeted and safer surgery or more personalized choice of medications in the future for treating glaucoma more effectively.
Sounds good. With that, Anthony, it's been a pleasure having you with us. Congratulations on all the good work that you have shared with us, and I'm sure that in due time and not so far distant future, we would have even more exciting new findings from your research, and hopefully we will be able to get you to share with us in another platform. So thank you very much for your time. Thank you, Clement, for the question, for joining us in this panel. And to all our participants, I hope you enjoyed that 1 hour of webinar that we have organized on a monthly basis here in NUS. I would like to encourage you to follow us on our socials, and till the next time. Anthony, thank you very much once again. Clement, thank you very much for your time.
Yes, thank you, Anthony. It's a pleasure
Thank
meeting
you
you.
all. Thank you. See you soon.
See you soon.
See you
Yes.
soon, Anthony.